Welcome to Unit 1 of the Urinalysis and Body Fluids course. We will be talking about quality assessment and safety. Be sure to have the appropriate chapter in your textbook open so you can follow along in your textbook with the presentation. Quality assessment is abbreviated QA, and it's a program of checks and balances to ensure the quality of a laboratory services. It must involve a mechanism for error detection and provides an opportunity to improve services. So in the real world, errors do happen. What needs to be done is we need to identify the cause of the error, create a solution, implement the solution by retraining individuals, and then make sure that the solution has worked because we shouldn't have that problem again. It's an ongoing process all the time in the clinical laboratory, and QA encompasses all aspects not just of the urinalysis laboratory, but every area in the laboratory. There are three components: the pre-analytical, the analytical, and the post-analytical. And in every subject that you study, you must be aware of these three components in every laboratory test that you will perform. The pre-analytical components include all procedures that occur before the testing is done. First, we need to ensure appropriate test ordering processes. People need to be trained on how to use a laboratory information system, or if you're using paper to put the test, what information needs to be on that requisition and how that's properly filled out. Specimen collection, the transport of that sample, the storage of that sample, and the handling of that sample are crucial for the quality of laboratory results. And whenever we talk about a test, we will always say, what is the acceptable sample? How must it be stored? For example, urine at room temperature is fine for a certain amount of time. But after that, we need to put it in the refrigerator, if we can't test it right away, to preserve the elements we're looking for. Procedures for handling inappropriate or unacceptable samples. You will, if you work in a hospital setting, receive all kinds of samples that are mislabeled in a variety of ways or unacceptable for a variety of reasons. For example, we needed a purple stopper tube and they gave a blue stopper tube. There's nothing can be done. If an issue or a problem does arise, you need to have a method in place to document any of these problems or unusual situations. Primarily, it's who did you talk to, what time did you talk to them, and what did you tell that individual. We received a urine sample that was unlabeled. I'm sorry, you will need to recollect this sample as it will be rejected. We have to throw it away. One of the most boring parts of your job when you are first hired is reviewing these up-to-date available procedure manuals. They will have everything from soups to nuts about the department goings on, and you have to read and be very familiar with them. Anytime there's a change implemented in a procedure or a process, everybody has to sign off that they've been made aware that this has changed. And equally important is adequate personnel training and supervision. When you are first hired on in a new position, you will go through a comprehensive, depending upon how big the lab is, period of training. You'll have to read those SOPs. There are competencies that will have to be assessed, meaning they're going to watch you perform a procedure and make sure that you're doing it in accordance with the written procedure in their SOP. Once you have been deemed competent, then you can work not unsupervised. There will always be someone there to assist you. The pre-analytical, again, I want to emphasize, is the most crucial in the laboratory testing process. The laboratory results that are produced are only as good as the sample submitted. I can be the best MLT in the whole world, but if you give me a crummy sample, the results are going to be inaccurate. They will not be useful to the physician who wants to diagnose or treat their patient. Every laboratory will establish their own guidelines for sample rejection, but usually they're very similar across the board. In your textbook, there is a list of criteria for urine specimen rejection. Be sure that you are familiar with each and every one of these. Insufficient volume of urine for requested tests. Unfortunately, if you give me just a couple of drops of urine, I cannot do a complete urinalysis on that sample. It will have to be recollected. An inappropriate specimen type or collection. I needed a clean catch sample and I was given a midstream sample. Visibly contaminated specimens. In the urinalysis department, we need them to be free of fecal matter, toilet paper, any other types of debris that would indicate a contaminated sample. Incorrect urine preservative. We have what's called a 24-hour urine test, and certain tests require certain preservatives. So if you hand out the container with the wrong type of preservative, then the testing cannot be done. And 24-hour urines are not fun to collect for the patient. If the sample is unlabeled or mislabeled, it must be rejected. A request form is incomplete or lacking information. This is an easy fix. For example, if it's a written request and you don't have the patient's date of birth or the physician's name is not on there. So usually requisition request forms are easily resolvable. Unfortunately, unlabeled and mislabeled samples are the bane of our existence in the clinical laboratory. And you must stick to your guns, and if you do receive a sample that is unlabeled or mislabeled, it must be rejected. It must be discarded. There are certain exceptions, for example, cerebral spinal fluid, let's say you have brain fluid, some sample that is so difficult to obtain that it would endanger the patient more to get the sample recollected than it would to, let's go ahead and test the sample we have. But there are very strict guidelines in place in order to accept an unacceptable sample. Written guidelines must be present in the SOP manual to inform the staff on the procedure to handle the unlabeled or mislabeled samples. You never, ever, ever allow a staff member to come down and label an unlabeled sample or correct a mislabeled sample ever, ever, ever. The funniest story a colleague shared with us is they worked in a really big lab, and the nurse called down and said, "Oh my gosh, I forgot to label my samples. Can I please come down and correct or label that sample?" And the tech said, "Yeah, come on down." And so he had a whole rack of unlabeled samples, and he asked the nurse, "Which one is yours?" And that really brought it home to the nurse that unless it's labeled, it could be anybody's sample. The analytical components are the second phase of laboratory testing, and these are the components directly involved in laboratory testing. So you're going to have some type of equipment, some type of instrumentation that will actually analyze or process the sample. You have to have reagents and supplies, and you have to make sure that they're always in date. We cannot use expired materials. The procedure manuals with standardized procedures must be reviewed, especially if you're new, and never be afraid to go back and look at the procedure manual if you're unsure of a step to follow. What is the analytical method? Is it a microscopy procedure? Is it some type of analyzer procedure? So there's different types of analytical methods for different types of tests. Monitoring of analytical method, quality control. So every day with every piece of equipment, we run known samples called quality control material, and we know the results of these samples. And we have usually a normal, an abnormal, and sometimes we have a high, a normal, and a low. So we run these first. We run these before the patients, because if we don't get the results that the manufacturer lists, then patient sample cannot be run. It means something's wrong with our piece of equipment. The laboratory personnel, your technical skills, your training, monitoring of your work, technical competence is evaluated again upon hire at 6 months, then annually thereafter, and you must do continuing education. That's part of the CLIA, the Clinical Laboratory Improvement Act mandate, is that you keep up with your field and the newest things, or maybe procedures have changed, but it's crucial for a quality tech to have continuing education. We have a variety of analytical components at our disposal, and depending upon the size of your laboratory will determine the complexity of the equipment that you will be running. So first we have the equipment and the instrumentation. You can't just put a sample on, it produces a result, and say, voila, it's accurate. No, there's a lot of work that goes on behind the scenes on this equipment to ensure the accuracy of the testing. Some pieces of equipment require calibration. They all require preventive maintenance. How do you clean it? How do you take it down? How do you bring it back up? And then monitoring documentation of these actions. If you don't record that you did the QC, it's not done. In most modern labs, in large labs, this is all done through the computer. The machines talk to the computer and send the results. But in very small labs, you are the one who's responsible for writing down those results in the quality control manual. Reagents. The use of reagent grade or analytical grade reagents is required. Distilled or deionized water and quality monitoring. You can't just go to your tap when water is requested and get water out of the tap. That's not good enough. It's impure. We need laboratory grade water. Verification of newly prepared reagents before use. Anytime you open or reconstitute, meaning some of the reagents come as a powdered form and you have to add a specified liquid to make them into a liquid, you have to write the date this was done, sometimes the time it was done, and your initials on every vial that is opened. Procedure manuals should be current, they should be complete, they need to be readily available. And what's nice about computers is most labs will put these on the computer. It used to be that we had to have a procedure manual in every department and sometimes even on the floors so that nurses could look stuff up. What a pain it was to physically go and change out a page in these procedure manuals. They're comprehensive and they have to comply with the Clinical and Laboratory Standards Institute. CLSI is an organization which sets not just national but international standards for the performance of laboratory work. So all labs will buy these. They're not cheap. You have to buy them. And then we make sure that our policies, our procedures are in alliance with the CLSI standards. Standardization of technique in your particular laboratory is crucial. In general, all laboratories report out urine findings in a very similar manner, but there may be slight variations from institution to institution. So let's say that you worked at Lab A for several years, then you got a new job at Lab B. You have to be trained on how they report out the elements that are seen in a microscopic examination of urine. It may be slightly different than what you were used to. The microscopic examination requires adherence to the established procedure by all staff members who perform it. And this makes sense. If we all looked at the same urine sample microscopically, all of our results should match within a plus or minus 20% reference range. And that's why it's important that you don't skip over items that may be present in a microscopic urine sample. There are several standardized microscopic slides that assist in standardizing the microscopic exam. So when you get a job, again, your first thing is to be trained in resulting out in a standard way in compliance with your laboratory those results that you see. I can't emphasize enough the importance of standardizing the microscopic urinalysis. That's one thing we struggle with in education because Hospital A may report out these ranges, Hospital B may report out a different set of ranges that are still normal, but they're just a little bit variable. So some of the procedural factors that may affect the standardization is the volume of urine examined. We usually, are you going to do 10, 12, 15 mLs to spin down? The speed of your centrifuge has to be set at a specific speed. The length of time that the urine sample is centrifuged. This lab may do 5 minutes, this lab may do 4 minutes, but it may be because their centrifuge is slightly different. The concentration of the sediment that's examined, the volume of sediment dispensed. This is a big one. We're used to sometimes doing a manual where we just put a drop of urine sediment on a slide and look at it. But now there are slides that have little slots where we are all looking at the same volume of urine under the microscope. The reporting factors. Again, each laboratory will publish its own normal values based on a system used in the patient population. The one example I use for my students is think of people who live in Austin, Texas versus Denver, Colorado. There's a huge difference in elevation. So the people in Denver, the oxygen is much thinner, so the results of their hematology, their red cell count and their hemoglobin and hematocrit will be higher than those people who live in lower elevations. everybody needs to use the same words so that we're not confusing the physicians who may be reading our results. All personnel must report results in the standard format. This is relatively easy because of the use of computers, or they'll have standardized forms. And all abnormal results should be flagged for easy reference. Again, this will be something that will be in your SOP. In modern day instruments, the instrument sends the results to the computer, and the computer will flag, make it visible that this is an abnormal result. Internal quality control is abbreviated QC, uses materials that are used to assess and monitor analytical errors. Again, just because I put that sample on the machine and it spit out a result, it doesn't mean the machine's accurate. Maybe it's gotten off a little bit on its calibration. Maybe it's not interpreting certain colors or missing certain elements. So what we do is we have these materials, they're QC materials, that mimic patient samples. They're just like the patient, but we know what's in them. And there's usually a low, a high, and a normal. And again, it has the same chemical characteristics as true patient samples. We usually obtain these from vendors. Making them in the laboratory is ill-advised unless you work in a really large laboratory. We just don't have the time. The results are recorded, and tolerance limits as well as troubleshooting and corrective action procedures are established. So you run your control, and your high control does not give the right result. What do? So you go to your procedure manual, and they will walk you through the troubleshooting for when your QC is not in range. QC is always, always, always performed first before testing patient results, and it must be in. So again, you run this, you compare it to the manufacturers, and then you can go ahead and put your patient samples through. We also need to monitor personnel's analysis of the same sample. So sometimes we'll have a sample that is tested on day shift, and then perhaps later on we'll have the same sample, which is properly stored, tested by another person, and that's just an internal mechanism to make sure everybody's reporting out samples the same way. So every day, every time we use a piece of equipment, we do the quality control for our laboratory. But we also have to do external quality control on a quarterly basis. This is used to measure and monitor and evaluate a laboratory's performance compared with that of other laboratory facilities. These are called proficiency testing surveys, or programs, which many labs use the same lot of QC materials, and a report's useful for detecting quantitative small changes in systematic errors and quantitative methods. So what this means is there's a company that prepares these samples and they send them to laboratories across the United States. We test them, everybody tests them, we put our results in, and then they compare the results of all these labs across the United States. Now, the company knows what the results are. So if everybody comes within a certain percentage point, yay, good. It proves that your methods are valid. But let's say that your laboratory got a totally different result than the rest of the United States. Then that shows that something's wrong. Either there was a mechanical error or a personnel error. Something happened. So you're going to need to evaluate and do some corrective action so that type of error does not occur again. So this is very similar to the competencies that you will perform throughout the MLT program. Every course will have competencies, and these are exactly the same as proficiency testing that you will perform upon hire and then periodically throughout the year. So what we do is we have known samples and we give them to you as unknowns, and you analyze them, and your results must match within predetermined limits. Your results are not going to match ours exactly because we're not looking at the same sample of urine, the same drop of urine. But within plus or minus 20%, plus or minus 15%, your results should match ours. So in the real world, this is done. In the student laboratory, this is done. And this ensures that you are competent to perform the testing. The third piece of the laboratory testing process are those post-analytical components. And these are procedures that affect results, reporting, and interpretation. So we've collected the sample, we've analyzed the sample, and now it's time to get those results out to the physician. So we need to have an efficient and effective communication of results. We have to have a standardized reporting format with reference ranges and informative comments listed. Reference ranges is also known as normal values, and it lets the doctor know what this result is compared to what should be expected in a patient. The immediate reporting of critical values to healthcare providers according to laboratory policy. In a hospital setting, most laboratory personnel must report critical values. These are life and death values that the patient needs an immediate intervention. They usually require that you report to a licensed personnel, usually an RN, and you have to ask them their credentials, and you then document who you talked to, their credentials, and what time. Because if the nurse does not pass that information on and then something really bad happens to the patient, we have documentation that yes, these critical values were called, but unfortunately on the other end, the communication fell apart. So appropriate documentation and evidence of review. There will be somebody in the laboratory, usually a supervisor in large institutions, who will review all the records, the quality control, the outlying results on a regular basis. The goal of effective quality assessment program is to consistently obtain accurate and reproducible results. The test results should reflect the patient's condition at the time the sample was collected, rather than being modified due to procedural or personnel variations, meaning that something went wrong, that you didn't follow directions on the test and we got inaccurate results, or personnel didn't follow the guidelines for reporting out results in a microscopic urine to where different results were obtained that may lead to a different diagnosis. In the spirit of quality assessment, an action has not been performed if it has not been documented. And you will hear techs say all the time, if it's not documented, it's not done. This concludes the first part of Unit 1.